with Dr. John Bach, who's going to be speaking to us today about respiratory care. Please ask any questions. We will ask them to John at the end. And yeah, over to you, John.
Yeah, thank you. Thank you. It's wonderful to be speaking with you guys. You know, it makes me think of my days on the West End, and I saw some musicals there that never made it to New York City, and I had just a wonderful time. And okay, look, we're going to talk about how to prevent respiratory problems with SMA types 1 through 4. And I'm going to tell you right now, nobody with any SMA ever needs a tracheostomy tube, and no one ever needs to die from respiratory problems. And I'll prove it to you. So let's get started. First of all, what is NIV? Non-invasive ventilation, or what the doctors call NIV, has come to be synonymous with two things: CPAP, which is continuous positive airway pressure, and BiPAP, which is bilevel positive airway pressure. Now, I'm going to assume that you don't know the difference or what these are. I'll assume that. Continuous positive airway pressure is like breathing with your head out of the window of your car going about 60 miles an hour. It's a pneumatic splint. It's an air splint that splints open your airway so that you can use your respiratory muscles to breathe. It's completely useless for anybody with SMA. Totally useless because it doesn't directly help you get deeper breaths. Now, BiPAP is bilevel positive airway pressure. That is a flow of air coming at you when you inhale that helps you get a deeper breath. But there's also a flow of air coming at you when you exhale to stop you from fully exhaling. That is counterproductive. Nobody with SMA ever needs what they call the EPAP. Is there harm in it? Yes, but the harm is not that major. It's bad in every way, but only slightly bad. Well, so if people have to use BiPAP, I always tell them to set the EPAP to the minimum, which is 4 centimeters of water pressure. But we stopped using BiPAP 20, 25 years ago because the EPAP is counterproductive because it actually subtracts from the IPAP. So if you're getting an inspiratory pressure of 20, or say 12, like it's usually used, and you're getting an expiratory pressure of 5, then you're actually getting a pressure support of 12 minus 5, or 7 centimeters of water. However, that's minimal help or rest. It's not resting your respiratory muscles adequately. And how do you rest your respiratory muscles? By getting a pressure of about 18 to 20 centimeters of water when you sleep. So if you use non-invasive ventilatory support settings, in other words, you use high span BiPAP. When I say high span, I mean a span like an inspiratory pressure of 20, an expiratory pressure of 4. That's a drive pressure of about 16. That's what you would call high span BiPAP. Now that actually does help a great deal. Again, I don't use it because you have to increase the inspiratory pressure by the 4 of the expiratory pressure. And that sort of makes it less comfortable, less effective, counterproductive, and so on. I write about all this in my books and articles. I have 9 books on this and 280 articles. But at any rate, I'm just telling you that you can use BiPAP, but if you use it, you've got to use settings that will optimally rest your muscles during sleep, which is at least a span of 15 centimeters of water. So, 19 and 4 could be okay. 22 and 4, 25 and 4, okay. But using 8 and 4 is virtually useless. Okay. Now, if you don't understand what I mean by all this, I will direct you to a website, breathenvs.com. Now, that's www.breathe. NVS stands for non-invasive ventilatory support, nvs.com. But I've got an image of the website later on too, so you can copy it down then. Now, what is NVS? Okay, non-invasive ventilatory support. What we use on our older kids and adults is volume support or volume ventilation. See, a ventilator can be set to deliver a volume or a pressure. However, if you deliver a volume, that creates a pressure in the lung, and if you deliver a pressure, that puts a volume of air in the lung. So for you and me, our volumes for our normal breaths are about 500 to 600 milliliters. To get that volume, we've got to basically create a pressure of about 15 to 18 centimeters of water, basically. If someone gives me a volume of 600 milliliters, that will create a back pressure of about 15 or 16 centimeters of water. If they give me a pressure of 16 milliliters, that will create a volume of about 600 milliliters, okay? But what's the difference between setting a volume and a pressure? Well, if you set a volume, then you can take the volume and not exhale it. And you can take another volume on top of that and another one on top. So you can get a very, very deep breath, which will help you keep your lungs healthy, elastic. You have a stronger cough, and you'll be able to speak and yell and talk longer. That's what we call air stacking. And again, I'll talk about this later on also. But this is the main reason why we prefer to use volume ventilation than pressure ventilation. Now, BiPAP is a type of pressure ventilation. You cannot get a very deep breath by using any pressure ventilation. We do put people on pressure ventilation sometimes when they get too much air in their bellies. If they're getting volumes and the volumes are going into the stomach, then we can set a pressure that will give the volume, an adequate volume for a breath, but it may be less than the volume needed to go into the stomach. Anyway, this is getting kind of technical. I just want to tell you that it's always preferable to have a machine that delivers a volume. And no BiPAP units do that. Now, there's something called AVAPs and IVAPs, a volume targeted pressure support. I do not use that because when you target a volume, you don't get a deep breath. And so the lungs get small and stiff. A lot of people use IVAPs and AVAPs, and it'll work overnight and ventilate you, that's fine. But as long as you get a lot of lung volume recruitment and do a lot of air stacking during the day, there's probably no harm in using volume targeted pressure support at night. There's probably no harm. But I prefer to let my patients be able to use volume even during sleep so that they can stack those volumes and scream and yell and cough without necessarily having to wake somebody up to help them. So we use non-invasive ventilatory support settings, whether they be pressure or volume. And you can use NVS settings on BiPAP, but nobody does, mainly because BiPAP is usually prescribed by what they call sleep doctors who treat old men who snore, but understand this, polysomnograms are not programmed to interpret the problem as being from a weak diaphragm. They're simply not programmed to do that routinely. So the polysomnogram says the patient's having a central or an obstructive apnea, which is like blaming the brain or the throat for what the diaphragm cannot do. So the sleep doctors put people on CPAP and BiPAP, but they don't correct the carbon dioxide, which keeps getting worse. So nobody with SMA1 ever needs a polysomnogram. Why? Because everybody with SMA type 1 has paradoxical breathing. So in other words, the belly goes out and the chest sinks in if you have SMA type 1, and for 50% of people with SMA type 2. When a child has paradoxical breathing, they must be on nighttime NVS, or their lungs will not grow, and they will not get deep breaths, and their chest walls will get stiff, and their lungs will get stiff. So I'm going to repeat that again. Half the people with SMA type 2 who have paradoxical breathing, and everybody with SMA type 1 needs to get deep breaths during sleep, or their lungs will not grow. People who do not have paradoxical breathing probably don't need anything during sleep. Half of people with SMA type 2 don't. And their only problem is a weak cough, which we will talk about. But I want to make clear that I use the abbreviation NVS because the people who write NIV, all their patients end up with trach tubes because they don't understand that they need to use NVS settings. Okay? And if you have questions about that, I'll answer them for you later on. There are three aspects to management. There's long-term non-invasive management. There's extubation of patients who are too weak to breathe without sticking a tube through their necks. And the people who do get tubes in their necks, we offer to decannulate them. Now, we won't decannulate ventilator-dependent children under the age of 12 because they get too frightened. But we do take the trach tubes out of people who are 24-hour vent dependent if they want to get the trach tube out. 4 out of 5 people on trach ventilation will die because of the trach tubes. But some people can live 20 years or more on trach ventilation. Most people don't, and when they die, it's because of the trach tube. So we do offer to take the trach tubes out of people who never should have gotten them in the first place because the doctors did not extubate them to non-invasive ventilatory support and the cough assist. By the way, anybody who writes about NIV or NVS and does not mention the cough assist will not be able to keep their patients free from respiratory problems and complications and tracheostomy tubes, because cough flows are even more important than ventilators. People go into respiratory failure first because their cough is weak and they get intubated. The only people who go into respiratory failure without being sick are people who are treated with oxygen, because the oxygen tells the brain you don't have to breathe, the carbon dioxide goes up and they become comatose. Then they get intubated and the doctors tell them they need trach tubes, which is not true. So it's very rare for a patient to go into respiratory failure without being sick, with a cold, without being on oxygen. Nobody with neuromuscular disease should be on home oxygen therapy unless they agree that they want to die, because the oxygen and morphine will let them die sooner. But otherwise, nobody with neuromuscular disease should be on oxygen at home. Oxygen is not a substitute for getting the breaths that you need for normal ventilation. It's not a substitute for getting the secretions out of the airway by using the cough assist, okay? That's extremely important. Now, who needs tracheostomy tubes? My ALS patients do. Why? Because they have upper motor neuron disease. SMA is strictly lower motor neuron disease, which is why my SMA patients never need tracheostomy tubes, okay? SMA type 1, in 1995, I told the parents of 2 kids that if they didn't get trach tubes, they'd be dead within 1 year, because they have virtually no bulbar muscle function. They cannot speak, they cannot swallow, ever, even when they were 4 months old. I will show you what they look like now and tell you more about them later on. But the point is this: myopathy patients, muscular dystrophy patients, SMA patients do not have upper motor neuron disease, which is why they do not ever need tracheostomy tubes for ventilatory support, okay? The older boy here, Michael, I told his parents in 1995 that if he didn't get a trach tube, he'd be dead within 1 year. Then mom got pregnant again, had another boy. Now these boys have been 24-hour dependent on nasal ventilatory support since 4 months of age. They have 0 vital capacity, but they did not die in 1995. This is a photo of them in 1998. This is in 2010, 2012, and this is basically what they look like now. Now, these boys have severe SMA type 0. They were 24-hour vent dependent before 5 months of age. But they don't have trach tubes. However, they do have NG tubes, because not only did their mom and dad not agree to a trach tube, they never agreed to a gastrostomy tube. The gastrostomy tubes don't help when you're giving nasal ventilation, but you can get used to anything. These boys have had NG tubes since they were 4 months old. They don't even notice them. And they have no muscle movement at all. They can only move their eyes a couple of millimeters. They cannot grimace. They cannot move their tongue a millimeter. They have no bulbar muscle function at all, but they don't have trach tubes. So why do doctors think that you need trach tubes if your bulbar muscles are bad? Well, adult pulmonologists think that because, like me, they have ALS patients. And ALS patients do need trach tubes because their upper airways collapse because they have upper motor neuron disease, not SMA patients who have lower motor neuron problems, okay? And pediatrics, they don't have ALS patients and they don't realize the difference between the two. oh, this is really what they basically look like this year. Okay, they have no muscle movement at all, but I'm prescribing risdiplam for them, and that may very well help them. They have zero vital capacity for the last 15 years. This is another boy whose parents, I told, would be dead within 1 year if he didn't get a trach tube in around 1995. Here, he has typical SMA type 1. 2 copies of SMN2, just like the other boys, but he's about a year old here, and he's getting nasal ventilatory support. Now, he didn't die at 1 year of age. Here he is doing trick or treat with his brother and sister. The 2 boys I showed you, the brothers, they were not hospitalized and did not go into respiratory failure. They became 24-hour vent dependent a few weeks after I started them on nasal ventilatory support. They became 24-hour vent dependent at 4 months of age without ever going to the hospital or ever going into respiratory failure. They did not get intubated because they were on ventilatory support settings from the beginning. So you don't have to go to the hospital and go into respiratory failure because you have SMA type 1. In fact, the first time these boys were hospitalized, the only time they were ever hospitalized for respiratory problems, one was 8 years old, the other was 12 years old with pneumonia from a cold. The cough assist prevents pneumonias 90% of the time, but not 100% of the time. We intubated them for about 1 week, and then after they met our criteria to be extubated, we extubated them back to non-invasive ventilatory support and sent them back home. So they have only been hospitalized once each for respiratory problems at 8 years of age and 12 years of age, and we intubated them, then extubated them back to what they were doing since they were 4 months old. And that's the last time they've been hospitalized. Now they're 25 and 23 years old with no tracheostomy tubes, with severe SMA type 1, 24-hour vent dependence since 4 months of age. This boy is very different because his brother and sister kept bringing cold germs home from school. He was intubated 10 times before the age of 4.5. 7 times, okay, but the other times it was because he went to New York City hospitals that did not know how to take care of him. So, of course, they wanted to trach him, but 3 times he was transferred to us and we extubated him, put him back on non-invasive ventilation and sent him back home. Now, he was intubated 10 times before the age of 4.5. When he was 16.5, he got a bronchitis. His parents spent 2 weeks working with the cough assist with him, and he and his parents were exhausted. So we put him in the hospital, intubated him for 24 hours. He slept. Everybody slept. Then we extubated him back to nasal ventilation and sent him back home. That was 9 years ago. No, that was almost 11 years ago. He's now 27 years old with SMA type 1, and he has only been hospitalized once since he was 4.5 years old. And that hospitalization we might have been able to avoid, but they were totally exhausted. Everybody needed to sleep, so we intubated him for 24 hours. And this is basically what he looks like now. We have about 100 patients with SMA type 1 on non-invasive ventilatory support. This is a girl from Iran. She has SMA type 1. She's now 25 years old. And the last time she was hospitalized, she was 12. Before that, she was hospitalized 5 or 6 times, almost every year, for pneumonia. But we always extubated her and sent her back home. Now, I got to tell you something. The mothers of these kids become better than respiratory therapists. Her mother and she are very, very close. When she was 12 years old and intubated and unweanable, the respiratory therapist I work with and I stood at the foot of the bed and said to her mother, "You extubate her." So the mother went and we said, "All right, take the air out of the cuff." She took the air out of the cuff, took the tube out and put the nose piece back on her. And we let her mother extubate her because taking the tube out is very easy. And then her mother's going to put the nose piece on anyway. So anyway, I'm just telling you. The mothers get great. Another little boy that we just recently transferred here to extubate to save his throat from a tracheostomy tube. How long can NVS be effective? Well, in SMA type 1, 27 years, 26 years so far. And I think that my SMA 1 patients are going to live to be 60 or 70. They have no reason to die. Duchenne patients over 30 years. I now have 2 patients with Duchenne over 50 years of age, 56 and 51 years of age, and I have many over 45 years of age. They also never need to die from respiratory problems, and they never need tracheostomy tubes. But many of the patients, they have severe cardiomyopathies, unlike SMA, and they usually die from heart failure. My polio patients now, I've got several that are still using non-invasive ventilatory support 24 hours a day since 1954, when they were taken out of iron lungs. That's 66 years. I have some lower motor neuron ALS patients on non-invasive support for 14 years now. But generally, ALS patients can only use 24-hour non-invasive ventilation for about 13 months, 6 to 13 months. Then they have to be trached if they want to continue to live. So nobody with any myopathic disease or SMA ever needs a trach tube. This is a woman who has been using non-invasive ventilatory support for 66 years. She had polio. She uses a lip seal at night because nasal ventilation was not, I'm the first person to use nasal ventilation in 1982. It didn't exist before that because I was living in France and I showed the French mouthpiece ventilation, and the guy I worked for said, well, ventilate them through the nose. So we did that. And then, we eventually published it. But before that, since 1950s, patients were only using a mouthpiece, and they used this lip seal at night. Like this, for example. He used it for 51 years with 0 vital capacity, 66 years, 24-hour non-invasive ventilatory support, but she had polio. ALS patient, 14 years, 24-hour non-invasive ventilation. So this is the point. People with lung disease need oxygen. People who are too weak to breathe need ventilation. If you give oxygen to the patients who need ventilation, they will stop breathing from CO2 narcosis. They'll stop breathing because the brain basically gets turned off from breathing. But doctors are used to treating people who need oxygen because they have lung and airways disease. That's the problem. So they give everybody oxygen and bronchodilators, which are not only not helpful, they're actually harmful for people with SMA. In fact, if you are put on oxygen and sent home after being short of breath, you will be back in the hospital in respiratory failure sooner than if your doctors do absolutely nothing for you. And people on 24-hour non-invasive ventilatory support have fewer hospitalizations than people with tracheostomy tubes, even if they don't even use a ventilator. The trach tubes cause many, many complications. Even if you don't use a ventilator, you're going to be in trouble sooner than people on non-invasive ventilatory support. We published that in 1998. And nobody really cares because in the United States, you don't make any money by keeping people healthy. You only make money by sticking invasive tubes in their throats, in their necks, and everything else. That's the only way. And doctors are in debt. It's very difficult now. The entire American medical system is geared towards invasive procedures, not keeping anybody healthy. And again, in 1998, we reported this. The oxygen is bad. So not only does it turn off your breathing, but it makes the oximeter useless as a gauge of those 3 problems. If your saturation goes less than 95, it's got to be because of high CO2 or airway secretions. And if you don't get the secretions out, you end up with pneumonia, lung collapse, atelectasis, and so on. Okay? And then you have to go to the hospital. So if you give even 25% oxygen, then you can have severe CO2 retention and terrible oxygen airway secretions, and you don't even know it because the saturation can still be normal. And you end up with pneumonia for that reason, okay? Pulmonary function testing that's used in the United States is absolutely useless for people with SMA. Why? because it's designed for people with lung disease and airways diseases. They measured diffusion, arterial blood gases, plethysmography, forced expiratory volumes, and even polysomnograms, bronchodilator therapy, and so on. None of that is relevant for people with weak muscles. People with weak muscles need pressures to the body or the airway to help their muscles breathe and cough. They don't need oxygen and bronchodilators. Now, can bronchodilators be helpful when you're sick? Probably. So when people have colds, my patients tell me that it seems to help them clear their secretions when they're sick. But you shouldn't take it routinely because it sensitizes the myocardium to sympathetic stimulation, which can maybe increase their risk of having cardiac arrhythmias. PFTs are really almost useless for people. The only thing that's of any value at all is the vital capacity, but the vital capacity needs to be measured supine as well as sitting, and they don't do that with PFTs. So polysomnographies are completely useless for anybody with paradoxical breathing. Now, if you are symptomatic for having weak muscles and an elevated carbon dioxide when you sleep, you do not need a polysomnogram. The people who need polysomnograms are people with normal muscle strength who snore and have obstructive sleep apnea syndrome. They need polysomnograms because they can benefit from CPAP. SMA patients should really never be treated with CPAP. They need either high-span BiPAP or better, assist-controlled ventilatory support settings, okay? Let's say that you have SMA 2 or 3 or 4, and you're symptomatic, you have morning headaches, you get sleepy during the day, and you get fatigued. Does that mean you need a polysomnogram? No. What it means is you need nighttime nasal NVS. That's what it means. And if you try that and it doesn't make you feel better, don't worry about it. Try it again next year. Nobody should be put on nighttime ventilation because of any respiratory parameters. You should only use nighttime ventilatory support settings if you're symptomatic and it's because of weak muscles. How do we know if it's because of weak muscles? Because your vital capacity is less than normal, okay? If your vital capacity is supine and sitting, if it's 90% of normal and you snore and you're symptomatic, you probably have obstructive sleep apnea syndrome. You don't need a ventilator. But if your vital capacity is 60% sitting and you have these symptoms, you don't need a polysomnogram. You need to try nasal ventilation at night. If it makes you feel better, you're going to use it. And if it doesn't, you don't use it. That's all. If you have to prove to the healthcare system, what do you call it, HMS? I forget, in London. At any rate, if you have to prove to them that you need it, you can do a sleep, oxygen saturation, and CO2 study and show that the CO2 goes up and the oxygen dips down, okay? And that should be proof enough that you need a ventilatory NVS. You shouldn't have to do a polysomnogram, but you know, the bureaucrats don't understand this. So is there any harm of doing a polysomnogram? No, there's no harm. Just don't use CPAP or BiPAP. And if you're going to use BiPAP, increase these settings to much greater than what the sleep doctors would use. Because the sleep doctors don't look at your CO2. And the CO2, you don't get adequate rest at the settings they put you on, usually, okay? Unless they're really knowledgeable about this stuff. And I haven't met too many that are in any country. Hopefully you're better off in England, but I have my doubts. So why is a trach so bad? Number one, it's a foreign body that is always colonized with pathogenic, bad bacteria. Anybody with a tracheostomy tube has as much bacteria, pathogenic bacteria in their lungs as anybody with acute pneumonia, okay? That's why these patients have a high incidence of recurrent pneumonias. And up to 65% of patients with trach tubes get tracheal stenosis where the trachea closes down. And then you cannot remove the tube anymore, okay? Also, you get damage to the trachea called tracheectasis and tracheomalacia. 4 out of 5 people on trach ventilation die because of the tube, because they hemorrhage to death, they get repeated infections, They get fistulas between the esophagus and the trachea so that the food from the stomach goes into the lungs. All of these problems. And I'll tell you something else. Spinal cord patients who don't have any bulbar muscle weakness, when they get a trach tube, 30% aspirate because of the tube. When they take the trach tube out, 7% still aspirate for the rest of their lives because they had a tube. The trach tube goes through the swallowing muscles in the neck. It makes it more difficult to swallow. And that gives the doctors an excuse to put in a gastrostomy tube as well as a tracheostomy tube. When with SMA, you shouldn't need the trach tube. You definitely need the gastrostomy tube if you have SMA type 1, and some people with SMA 2. But you know, it depends. Nobody needs a gastrostomy tube early because you're going to get weaker and have more risk of respiratory problems if you wait too long. That's nonsense. We put in gastrostomy tubes in patients with zero vital capacity, without intubation, without sedation, under local anesthesia by an interventional radiologist. Anybody can have it done that way. And if you're too fat to have it done that way, you can get it done as an open gastrostomy, also without general anesthesia or intubation, okay? So when the doctors say, oh, get a gastrostomy and a trach tube, it's just an excuse to try to do both when the patients don't need it. SMA1, you're gonna end up needing a gastrostomy tube unless all these medications that are out there now really make you much stronger. And it's true that when you go from SMA1 to walk, you're basically becoming an SMA3. And if you get these like nusinersen, possibly risdiplam, and Avexis 101, Zolgensma, at birth, you may very well be converted to an SMA2 or an SMA3. Now, with SMA 1, 2, and 3, you still have a high risk of pneumonia and go into respiratory failure because even if you don't need a ventilator, the cough gets weak, okay? Even with SMA 3, the cough can be weak and you can have an increased risk of getting pneumonia as a young child. Not very young, but you know, a child. SMA 1 and 2, definitely. There's a risk of getting pneumonia because the cough is weak. Excuse me. So also, everybody on trach ventilation, they get overventilated and their CO2s go down. This makes them more dependent on the ventilator. When we take their trach tubes out, the CO2s become normal and they wean from the ventilator if they have a vital capacity of at least 250 milliliters. Also, invasive mechanical ventilation makes the diaphragm weak. It deconditions the diaphragm. And of course, you could die from all these other problems, cellulitis, pneumothorax, pneumomediastinum, hemorrhage. People with trach tubes can die for many reasons, and it's because of the tube. ALS patients, 32 out of 40 died because of the trach tube. My patients. Duchenne muscular dystrophy, none of my patients die from respiratory problems. Most actually die from heart failure. But like I said, we've got a couple of patients now over 50 years of age on non-invasive ventilatory support for 30 years. So there are 3 respiratory muscle groups: breathing, expiratory, which is coughing, and the glottis, the throat, the bulbar muscles that protect the airway. The inspiratory and expiratory muscles can be 0, not a problem. You can get breaths by frog breathing, by using a mouthpiece ventilation, nasal ventilation. Non-invasive ventilatory support replaces the inspiratory muscles. The expiratory muscles are replaced by the cough assist or the nippy. In England, you've got the nippy. That's a good machine too. We don't have any substitute for the bulbar innervated muscles. But you don't need any bulbar innervated muscles to protect your airway, provided that you're properly positioned. So why don't my SMA1s get pneumonia from aspirating saliva? Because their parents know how to position them. In the wheelchair, they sit forward and drool. When they're lying in bed, their head is to the side. The secretions do not go in the airways. It's as simple as that. It's a question of positioning. Now, how do we evaluate people without PFTs, pulmonary function testing? By painlessly measuring their carbon dioxide at the nose with a captograph, an end-tidal CO2 monitor. Or you can use transcutaneous CO2 also. an oximeter. This is a very old oximeter. A $15 peak flow meter. We use this to measure cough flows. The patients cough into here. When the flow is over 300, there is really no risk of getting pneumonia with a respiratory infection. The lower it is below 300 liters a minute, the greater the risk. And of course, a spirometer. Now, the spirometer is important for many reasons. I recommend a non-digital spirometer. I recommend non-digital everything. I don't like digital computers. You know, the ancient Greeks had a non-digital computer. I'd love to get one of those. I don't like anything digital. The problem with digital stuff is when you trigger it, it has to be reset. With this spirometer, you can air stack and blow into it. You know, you can do many things with this that you can't do with a digital spirometer. So this is from England, basically. This is a Wright spirometer. It was originally made in England. I think it may still be. And it's wonderful. So we measure the vital capacity sitting and lying down, but also the air stacking ability and the lung insufflation capacity. If you can't close your glottis and you cannot air stack volumes of air, we can still fill your lungs with air passively in many ways to expand your lungs to keep them healthy, and we can measure that volume. The greater the volume we can put in your lungs, the healthier your lungs are. We call that the lung insufflation capacity. Kids with SMA type 1 cannot air stack.
Yes, I was going to say.
Most people with type 2, 3, 4 can air stack. But if you cannot really air stack well, then we passively fill the lungs and we measure that volume too. You have to have a spirometer like this to do that. Now, as the vital capacity goes down below 40%, the cough flows become ineffective. And that's because for an effective cough, you not only need your expiratory muscles, which are mainly your abdominal muscles, you also need to get a deep breath. A normal volume of air is about 500 milliliters, but a normal cough is 2,300 milliliters, okay? So we take a deep breath and then cough. We don't exhale and cough. So it's very important to both get a deep breath and also get the negative pressure to increase the cough flows. So our treatment goals are to optimize lung volume recruitment, optimize cough flows, and maintain normal ventilation. And the way we maintain the elasticity of the lung is by air stacking. Now, the patients either get the breaths through a mouthpiece. If the lips are weak, we inflate them through a lip seal. So the patient gets a volume of air from the ambu bag, holds it, gets another volume, and holds it, gets another volume. If she starts leaking out of the nose, then we can use a mask that covers the nose and mouth and inflate her that way. But she has to hold the air with the throat. And then she blows the air into the spirometer, and we get the maximum insufflation capacity. Now, that's basically an indicator for how strong your bulbar muscles are, okay? You can also air stack without an ambu bag or a ventilator by frog breathing. So for example, I can air stack a few liters by simply using my tongue. So you can take a deep breath and then frog breathe on top of that and approach your maximum insufflation capacity. So some people actually frog breathe deeper than what they can do with an ambu bag by air stacking. Most people can air stack deeper than they can do by frog breathing. So it's good to do both. Learn how to frog breathe and also air stack. This is a 48-year-old Duchenne who is able to air stack to 1.6 liters at 47 years of age. But after the age of about 38, his vital capacity basically went to 0, and his ability to frog breathe became ineffective after about 42. So how did frog breathing help him? Well, he was grabbing the mouthpiece a few times a minute to get deep breaths to supplement his breathing. So when he was 39 years old, his vital capacity was 500. So he could get a decent breath, but he would supplement that by frog breathing. But when he got to be 43 and his vital capacity was less than 200, the frog breathing really didn't help him anymore. And he had to grab the mouthpiece for every breath. How many times did he grab the mouthpiece? Well, you have a choice. You have to have 6 liters of minute ventilation, you and me both, you could get 15 breaths at, you can get 12 breaths at 500 milliliters. You can get 5 breaths at 1200 milliliters, or you can get 4 breaths at 1500 milliliters. So he would get 1200 milliliters or more and grab the mouthpiece a few times a minute, and he was doing fine. When you air stack through the nose, you can also blow the air into the spirometer, and we measured that as the maximum insufflation capacity, which is the ability to air stack. See, you can air stack through a mouthpiece, a lip seal, through the nose, or through a mask covering the nose and mouth. If the lips are weak, then we let the patients air stack through a lip seal or through the nose, and they blow it into the spirometer. Oh, and now this is a patient with a vital capacity of 900 milliliters who frog breathes up to 2,800 milliliters. So you see, that's like air stacking to almost 3 liters. And when she sleeps at night, she can wake up and frog breathe to 3 liters, and then she can cough, she can shout, get help, you know, because she's able to frog breathe to 3 liters of air almost. This is a patient with 0 vital capacity who frog breathes all day for 500 milliliters, 12 breaths a minute, and can also get deep breaths by frog breathing as well. The second goal is to optimize cough flows. So, and we do this because the greater the flow, the more effective the cough. And why? Because a mucus plug can cause the lung to collapse in minutes. So 90% of mortality in kids with SMA and in muscular dystrophy are caused by respiratory infections triggered because the patients can't cough effectively. 90% of mortality and intubations in SMA types 1 and 2, and for that matter, type 3, and in muscular dystrophy, are caused by weak coughs. And like I said, you need to get a deep breath. You need to create a thoracoabdominal pressure. You need to hold that pressure with your glottis and then cough. And we measure the cough flow. And this is an unassisted cough flow. But then we pump the patient up, press on the belly, and we get an assisted cough flow. Now, at the assisted cough flow, the unassisted cough flow may be 100. The assisted cough flow may be 300. If the assisted cough flow is over 300, and the patient has somebody at home that will help them cough all day long when they get sick, they don't need a nippy. They don't need a cough assist, okay? However, if they don't have people to help them cough enough, they really do need a cough assist when they get sick, or a nippy when they get sick, okay? Because you can get those kinds of flows with the mechanical insufflation, exsufflation. So if you ask me, what is the most important image you could show that indicates why you never have to trach your patients, it would be this one. Because with assisted coughing, ineffective cough flows become effective. And if you have an effective cough, you never need a trach tube, because you can always ventilate people by non-invasive ventilatory support. You never need a trach for that. The cough assist here we use, it should be used at 50 to 60 centimeters of water pressure through the upper airway, or 60 to 70 centimeters of pressure through a translaryngeal tube or a tracheostomy tube. Never at less than 500 centimeters of water pressure for SMA. For ALS is different because their upper airway closes and you may need to use lower flows on them. But with SMA types 1 through 4, we always use pressures over 40 centimeters of water, 50 to 60 usually, and even higher through the tubes. So this is a 2.5-year-old in Japan who Dr. Ishikawa took her trach tube out. They used the cough assist. And that's what I mentioned, 50 to 60 through the upper airway and higher through the tube. So now our next goal is to maintain normal ventilation around the clock. So the symptoms in babies and small children are perspiration during sleep, flushing, breathing rapidly, and paradoxical breathing. Paradoxical breathing is tiring, and the kids are struggling when their belly goes out and their chest sinks in, okay? They need nighttime NVS, or their lungs won't grow and they will die. They'll just simply stop breathing and die. For older people, the symptoms are morning headaches, fatigue, daytime drowsiness, decreased appetite, depression, decreased concentration, and so on. Those are basically the symptoms. Now, when you have those symptoms, you need nighttime ventilation. You have those symptoms and a decreased vital capacity, you do not need pulmonary function testing. You do not need polysomnography. You do not need BiPAP, and you better not get oxygen. You need NVS. So how do you begin it? Okay. For babies with SMA type 1, we put the patient on nasal NVS in the clinic, and we show the mother how to put it on the baby when the baby's sleeping. So now, at first, you let the baby sleep, and when the baby goes into deep sleep and the eye starts moving like in REM sleep, you put the nose piece on, and the baby's not going to try to knock it off because they're in deep sleep. And then you give a little bit of positive pressure. You gradually build up the pressure, and I guarantee you within 1 week, the baby will not want to go to sleep without using nasal ventilation because they understand that it makes them feel better. It's amazing, but they understand this even when they're less than 1 year old. So we let the mothers put the kids on. I've seen so many articles on nasal ventilation where they say, must be carefully controlled in the hospital by experts, blah, blah, blah. Nonsense. It's absolutely absurd. We show the mothers how to do it, and we send the mothers home. We show them how to adjust the ventilator. It's not rocket science. It's just a box giving you air to give you deep breaths. I mean, it's just incredible. And we let the mothers, and how does the mother know that the kid is doing it well? When the paradoxing is no longer there. Instead of the chest going out and the belly going out of the chest sinking in, both go out. And the child is in synchrony with the machine. And when the chest expands, the lungs grow, there's no more paradoxing, and the symptoms decrease or go away. Okay, that's how the mothers know that she's doing it properly. Now, for older kids and adults, it's a question of, again, showing them how to use nasal ventilation in the clinic. And then we have home care companies in the United States that bring the ventilator and the interfaces to the patients, and they show them how to use it, show the patients how to adjust the settings to increase the settings when they're sick, or find out. I always write a range of like 700 to 1500 milliliters. I write that range. Now, my patients usually start at 700 milliliters, but they all end up at 1100 to 1200 to 1300 milliliters, all of them. Now, some of my patients use 1800 milliliters, and I have one patient that used 2,500 milliliters. It doesn't matter because the brain takes as much of the air as it needs, unless you give the brain sedatives and oxygen. Once you give the patient oxygen or narcotics, all the air going through the nose just leaks out of the mouth, and the CO2 goes up, and the patient stops breathing. That's what happens. So nobody should be on really any oxygen at home, and you got to be very careful with sedating medications. If the patient says, I don't feel any better using this, I don't want to use this, okay, we'll check you again in 6 months or a year. My ALS patients, they have to come back in 2 to 3 months, but with SMA, 6 months to a year is generally adequate. And we see how they feel then, maybe put them on nighttime ventilation then, and see how they feel. If it doesn't make them feel better, they don't need it. So the ventilator is like a pickup truck for a weak muscle like this weak horse. When the horse is struggling, it needs a rest. The ventilator rests the muscles overnight, not BiPAP at 12 and 5 or 8 and 4. No, you got to use, if you're going to use BiPAP, at least 18 and 4, 21 and 4, 25 and 4, something like that. But again, I don't recommend BiPAP for many reasons. And if you rest the muscles at night, I guarantee you that your daytime blood gases will be better. You'll be less tired. Your symptoms will be better. Everything is better if you use the ventilator at night at adequate settings. It's better until you get much weaker, and then the carbon dioxide starts to go up during the daytime. But you don't need to use the ventilator during the daytime, except during colds, until the CO2 goes up high enough that the oxygen saturation goes below 95%. With SMA type 2, that usually never happens. Even my patients that are 50, 60 years old, it's true it can happen at that age for SMA type 2. SMA type 3, it is possible to happen. One of my 15 patients who's now in her 70s really needs to use nighttime ventilation. SMA type 2, I've got maybe 7 or 8 patients who need nighttime ventilation. But again, there's 2A and 2B. The patients with 2A have paradoxical breathing, and they always need nighttime ventilation. Patients with 2B who don't have paradoxical breathing, they may not need nighttime ventilation until they're in their 40s. Okay, that's the way it is. With SMA type 3, it's even later. I recommend against using BiPAP for many reasons. The LTV is a good ventilator. It can only be used with what we call an active circuit, so there's less risk of it being used badly. But it's not really on the market so much anymore. And I don't even know if it's still available. The Trilogy is good. The Astral is good. But I warn you, the Trilogy has 11 ventilation settings. 3 of them are BiPAP. If you have a Trilogy, you should not be using BiPAP settings. You can use an active circuit with settings without EPAP, which would be better and more comfortable. So if you have a Trilogy, it's sort of ridiculous to be using CPAP or BiPAP settings for people with SMA. You can learn more about this by going on that website, breathemvs.com. I should have this update of my 2004 book done in the next couple of months. And my patients I'm gonna have a full money back guarantee, because I know my patients will never give up that book, because it not only explains what's done to save their throats literally from invasive airway tubes, it explains to why their doctors have been doing it wrong for the last 40 years. It explains all of that. And this is a baby with SMA type 1. Before nose pieces were on the market for infants, we constructed them from infant prongs. But I don't need to explain that now, because now companies have infant circuits. And this is a flexible metal support arm that can hold the mouthpiece near the mouth for patients air stacking or using daytime ventilation, as some of the SMA type 2s and 3s do, and they certainly need it when they're sick. Dr. Affeldt in 1953 said about mouthpiece ventilation, when in 1952 in Denmark, patients got trach tubes to be ventilated because the doctors didn't know about non-invasive ventilation. However, and they didn't in the United States either, but in 1953, Dr. Affeldt saw that when they took the patients out of the arm and lung, instead of hooking them up to a trach tube, they said, well, they got the tubing and they put it in the mouth and they ventilated themselves, and you just hang the mouthpiece by the patients and they grip it with their lips when they want it, and when they don't want it, they just let go. It's just too simple. I don't know why they didn't think of that many years ago. That's what Dr. Affeldt said. That was 1953. The first article about this I wrote in 1993. That was 40 years later. But nobody paid any attention to it because American surgeons were making so much money putting trach tubes in people, okay? In 2013, Respironics put a mouthpiece ventilation mode on their Trilogy ventilator. Ever since then, there are now 200 centers around the world that have at least one patient on 24-hour non-invasive ventilatory support. Even in the United States and England, there are patients on 24-hour non-invasive support. The problem is that when they get sick and get intubated, the outpatient doctors lose control of these patients, and the critical care doctors think they need to be trached. So what I tell my patients is, under no circumstances agree to a trach tube. Force the doctors to call me or to learn how to extubate them back to non-invasive ventilation. I've had patients on non-invasive ventilatory support for 60 years, right? If they need surgery where they need to be intubated, why would they have to get trached? They could be extubated back to what they've been doing for the last 60 years. The same is true for people who haven't been using non-invasive ventilation. They can be extubated to nasal ventilatory support, just like my patients who've been on it before they even got hospitalized. Critical care doctors think they automatically have to wean people to extubate them. But that's obviously not true, okay? But to teach them something new is very, very difficult. Almost impossible. So my patients have to be firm. I will not agree to be trached. What they do is they make you comatose by giving you sedatives and oxygen. And they say to the family, we can't extubate this patient without a trach tube. Now, if the family doesn't know better, they agree to the trach. So when the patient wakes up with a trach tube, often they are outraged. I had a guy with muscular dystrophy in the Bronx, 15 years of 24-hour non-invasive ventilation. He woke up with a tracheostomy tube. He was so disgusted, he came to see me the next week, and we took it out immediately, the first visit in the clinic, after he got an unnecessary trach tube. And he was 24-hour vent dependent for 15 years before he even got pneumonia. So you don't need a trach tube. But if the patients don't demand it, the doctors will simply take the easy way out and stick it in. It's a disgrace, but that's the way it is. This is a Trilogy ventilator that has a KISS trigger, which is nice. When patients use mouthpiece ventilation during the day, you can set the backup rate to 0, and when you touch the mouthpiece, it just delivers the air. That's very nice. This is for pneumobelts. You don't even need a mouthpiece or a nose piece or a trach tube for full ventilatory support during the daytime. You can put this air stack inside this girdle. This goes under the clothing. The ventilator doesn't inflate the mouth, the nose, or the throat, or the neck. It inflates the air bladder in the belt. That presses against the belly, moves the diaphragm, and ventilates the lungs. People have been using this since 1937, but nobody cares. It's easier to put a trach tube in, let everybody get involved, right? Well, I have patients using this for over 50 years, and they don't need a mouthpiece during the day. They don't need frog breathing during the day. They don't need nasal ventilation. They don't need a trach tube. I actually have a patient who got pregnant. She was on a vent 24 hours a day for over 50 years. 20-something years ago, 30 years ago, she had a full-term pregnancy using a pneumobelt. And I said to her, what did you use when you went into labor? I used a pneumobelt. And what about, but she said, except the last 20 minutes when I switched to a mouthpiece. So you can even use a pneumobelt through an entire pregnancy. So the ventilator on the back of the chair can inflate the belt instead of the throat directly. And you can measure people for the belt. There's a company in Italy that makes these. It's called DIMA, Italia, D-I-M-A. And their belts are comfortable and they work very well. D-I-M-A. You can also use the pneumobelt with any other ventilator. Now, DIMA doesn't like that because, you know, they rent out the Luna ventilator, and they can't rent out the ventilator if you use a different ventilator to inflate their pneumobelts. Okay?
Is that the same as the Hayek? The Hayek H?
No, the Hayek, no. The Hayek is a biphasic chest shell ventilator.
Okay, yeah.
That does not go under the clothing. The chest shell goes over the clothing and it sticks out a lot. Now, I'll tell you, I don't really talk about chest shells here because I myself converted 40 people from chest shell ventilation to pneumobelts and mouthpiece ventilation.
They put
because,
that on,
you know, because the chest shell sticks out a lot and it's not as effective or comfortable as a pneumobelt. It really isn't, you know? So I took 40 people. Not only that, but when you use the chest shell at night, the negative pressure can cause the upper airway to collapse and get obstructive apneas, okay?
Yeah.
So 40 people switched to these pneumobelts because I once took a patient who was using a pneumobelt for 51 years with zero vital capacity to a pulmonary meeting in Toronto. And I said to the pulmonologist, this guy's got zero vital capacity, how is he breathing? Nobody could figure it out. You know, they saw the tubing go under his clothing, they had no idea what he was doing. And so I have patients who don't like people to know that they need to use a ventilator. You know, they teach children, they go out, they do things, they don't want people to know they're using a respirator. So they use a pneumobelt. You know, it's really a good ventilator. So how do you avoid respiratory failure? Okay, for the third time, I'm going to say this. Oximetry feedback to use CNVS, which is continuous non-invasive ventilatory support, and MIE, whether it be the NIPI or the cough assist, okay? So I tell my patients, when you get a cold or you start coughing, you put that oximeter on the finger and you do not let it go below 95%. If it does, it can only be because you're not getting deep breaths. Now, when you get sick, you end up using the ventilator 24 hours a day. Anybody using nighttime ventilation, when they're sick, they're weaker, and they tend to use the vent during the daytime too to get deeper breaths to help themselves cough. So if you're using the vent at night and during the day, you don't have to worry about ventilation. But if you're not using the ventilator, you have to be concerned that maybe your CO2 is high. But generally that's not a problem because, well, most of my patients, it is possible that you can have MIE and an oximeter without a ventilator. That is possible. But, you know, the NIPI and the cough assist will also ventilate you. So if a patient is short of breath and really needs ventilatory support during a cold, usually you know that, and you can help them with that. So number one, if they're using the vent 24 hours a day, the CO2 is going to be normal. I'll tell you right now. So therefore, the desaturation has got to be because of airway secretions. 99% of the time, that's what it is. So you use MIE, whether it be the NIPI or the cough assist or there's one in Italy, there's a Pegaso there and all these things, you know, there's 9 countries making these things now. And you get that saturation back to normal, or if the saturation baseline stays below 95, you got to go to the hospital. Why? Because if your saturation baseline is less than 95, you're at high risk of getting a mucus plug, and that can cause you to go into acute respiratory failure. One sort of clinical pearl that people need to understand is when you use the cough assist through the upper airway, or even through a tube, an invasive airway tube, initially the saturation can go down. Don't worry about it, because the secretions will still come out, and that's probably a transient airway collapse. I don't give oxygen to the patients. Within 1 or 2 minutes, it always goes back to baseline or higher. I don't usually remember to say that, but it's kind of important. I don't mind patients getting oxygen when they're being treated with the cough assist. The problem is you don't know as quickly how successful the treatment was. Because even if the saturation goes down for a minute while you're using the cough assist, it always goes back to baseline or higher. And if you use oxygen, you have to wait longer to know that. So again, don't use oxygen or sedative medications. All right, let's talk about extubation and decannulation. Critical care doctors think that to take a tube out of the nose or throat or mouth of somebody, to extubate them, you need to have an adequate cough, few secretions, and be able to breathe on your own. In other words, be weanable. None of my patients satisfy these criteria. Our criteria are to be healthy. The saturation should be normal in room air with normal carbon dioxide. In other words, with full ventilatory support, the saturation should be normal. But you should also be fully alert and cooperative. Your lungs should be improving, your CO2 40 or less, which is normal, and you should be afebrile with a normal white blood count. So in other words, you should be healthy, your saturation should be normal in room air, and somebody in the family better be there after extubation to use the cough assist for every desaturation below 95%. I will not transfer a patient to me to extubate them unless I have assurance about that, because they may need to use the cough assist every 20 or 30 minutes after the extubation. And I do not want the patient to get oxygen after the extubation. So if I tell the nurses to use it every 20 minutes, they're going to think I'm crazy. Nobody's going to do that. The respiratory therapists rotate, they come by every 3 hours. This is not an IPPB treatment. When you have bronchitis, you need to cough all day long. These patients need to cough all day long, and they don't have the strength to cough, so they need the cough assist to help them. You can't order the cough assist every 2 hours or every 6 hours. That's ridiculous. When you have bronchitis, you cough or you die. And that's true for you and me as well as for the patients. So that's why you got to have someone there to use the cough assist up to every half hour after the extubation for 24 to 36 hours. So this is a girl with SMA type 2. Now she teaches school. When she was 3 years old, she got transferred to us from a local hospital, an academic hospital, because she failed extubation a few times. They didn't know what to do. They thought she needed to be trached. But I had told the mother that, you know, she doesn't need it. So she got transferred to us. We extubated her. And then I didn't see her again for the next like 17 years. So she did well. She got transferred to us when she was about 17 also, because again, she got a pneumonia, got intubated there, got transferred to us. Then she was 29 years old and it happened again. Now, she is dolichocephalic. So in other words, she has a long face. And when we tried to extubate her, it was very difficult because the oral nasal interfaces often didn't go above her lower lip. So she had a tendency to leak. Usually we can extubate. She was using nasal ventilation for 24 years, okay? 27 years. She was an expert at using nasal, and wait a minute. No, she was using an oral nasal interface for sleep for the last, I don't know how many years, because of her dolichocephaly, because it was difficult to keep her mouth closed. So she was able to do that. But so to make a long story short, the reason that we were able to successfully extubate her again was because of this interface, which I like a lot. It's called the new mask. Now what it does is the foam blocks the nose and the mouthpiece phalange delivers air to the lungs. And she initially liked it. But when she went home, she said, no, I'm gonna go back to my oral nasal interface. And she tried to keep her lower lip up by maybe using a strap under her chin to keep the lip up. But at any rate, SMA type 2, and now she's about 31 years old, something like that. And this is the new mask. This is a 72-year-old who we extubated her. Anyway, this is another girl with SMA type 2. Now, she was from Santa Barbara, California. She's somebody who never wanted a trach tube, and she did not use a ventilator, but she got pneumonia, got intubated. Then they knocked her out so she couldn't speak, and they said to her family they could not extubate her without a trach. So she woke up with a trach tube, and she was outraged. They raised $80,000 in charity care to fly somewhere where they would extubate her. I'm the only one that would, to remove her trach tube, to decannulate her. I'm the only person that would remove her trach tube. And she was 24-hour vent dependent. She flew to us. We took her trach tube out. After we did that, she weaned to nighttime ventilation. Because like I told you, when you're on trach ventilation, you become unweanable. But when we take the trach tube out, if your vital capacity is at least 250 milliliters, you wean to nighttime ventilation. And that's what happened. This is a SMA 1 who's now 25 years old. She's the one whose mother, we let her extubate her when she was 12 years old. Last time she was hospitalized, which now is about 13 years ago. These boys, as I mentioned, they were intubated once in their lives when they were 8 and 12 years old, even though they've been 24-hour vent dependent since 4 months of age with SMA type 1. They have never been able to make even a vowel sound. They have had no bulbar muscle function and have had all nasogastric feeding since 4 months of age. Very severe SMA type 1. And now, of course, they're 25 years old, 23. And I mentioned with him, he was intubated 10 times by the age of 4.5, and he hasn't been intubated now in the last 9 years. He's 27 years old. So we reported 157 cases in 2010, SMA, 23 of them, 23 of the cases are SMA, including type 1s. We reported another 100 in 2015. Again, most of them were SMAs, type 1s and type 2s. All of them were unweanable when we extubated them. Excuse me, I'm sorry. Yes, hi, I'm doing a webinar. No. Yeah, I'm going to be here. I'm doing a webinar. I'll talk to you in a few minutes. Right, bye. Bye. Sorry. Yeah, so we will take the trach tubes out of kids, but if they got to be over 12 years of age. Now, let's say that you're the mother of a baby with SMA type 1, and you don't want that child to have a trach tube. but the baby has a trach tube. There's only one theoretical way to remove it, in my opinion. This was actually my colleague, Dr. Goncalvish's idea, but nobody has ever done this. If the child is vent dependent, you can intubate the baby, take the trach tube out, and then after the skin closes, you can extubate the child the way we do. We have essentially a 100% success rate, or close to it, extubating unweanable children with SMA type 1. So the reason that it's more difficult to take the trach tube out of a baby or anybody is because the ostomy and the tube causes more airway secretions because it's a foreign body with bad bacteria. But if you intubate, take the trach tube out, suture the ostomy closed, the secretions decrease, and then we can extubate without tracheing the person. Now, that's a theory. Nobody's ever done this. But, you know, I don't see any reason why it can't be done. The question is the baby better off with or without a trach tube? Well, in my opinion, they're better off without the trach tube. Because my SMA 1s, when they don't get trached, and they go into respiratory failure before they're 18 months old, many of them don't become 24-hour vent dependent until after more than 20 years of age. And less than half become 24-hour vent dependent before they're 10 years of age. Now, I am doing a study now on the patients who get trached. And basically all of them become 24-hour vent dependent from the time they get trached until they die. And usually they die from the complications of the trach tube. So I'm actually working on doing a paper like that right now, in fact, because historically, I used to have a lot of patients with trachs. I haven't in the last 30 years with SMA type 1. But I have patients with SMA type 1 who network with everybody in the world. And they know kids with trach tubes with SMA type 1. And I'm going to find out when they got trached, if they could breathe afterwards, and what the status is. And I suspect I'm going to find, like with my own experience, that as soon as they get trached, they never breathe again. And my patients, when we extubate them, even though they're unweanable, they wean to nighttime ventilatory support within 3 weeks, usually within 3 days. 22 centers in 18 countries got together in 2010, and we compared, we put patients together with SMA type 1 and also Duchenne and ALS. And we're not the only people who do this. There is no other center in the United States, but there are centers in other countries. Unfortunately, there's none in England either. But in Portugal, they do a great job at Porto, in Japan, in Hokkaido, and in other places. Now, if you go onto the website, breathemvs.com, you can see the centers that use non-invasive management. 6 centers, 101 with SMA type 1, begin. I don't even remember this image. Let me see. 100. Well, I put this on here because I was pointing out that when we extubate these kids, from all these 6 centers, there were 142 extubations of SMA type 1s. And in the other centers, only 8 got trached, and 13 died, and so on. We actually do somewhat better because we extubate the patients ourselves, see? So we manage them as outpatients and also if they get sick and get into the hospital. Whereas in the other centers, sometimes the doctors lose control of the patients when they get intubated, and then you got the critical care doctors telling them that they need to be trached. So that's the problem. Our Muscular Dystrophy Association, in their last monograph, said that in 22% of clinic visits, they discuss respiratory issues. Well, since all of their patients either die from respiratory problems or end up with tubes through their necks, frankly, I think this is a disgrace, quite frankly. I'm a doctor in an MDA clinic, okay? But 98% of the patients who come to see us get a respiratory evaluation on every visit. The only ones who don't are kids who obviously don't have any respiratory problems or adults who don't and are there because they have difficulty walking. But most of our patients are at the age, all of our SMA 1s, all of our SMA 2s, most of our SMA 3s, every time they come to our clinic, they get a respiratory evaluation because they need it. But these other clinics, they're run by neurologists who don't seem to know that. In the United States, I doubt if it's any better in England, quite frankly. 22% of the clinic visits, they discuss respiratory. They don't evaluate the patients. What they do is they send them to their friendly pulmonologists who may send them for a polysomnogram, and they're put on CPAP until they go into respiratory failure, then they get trached. That's what happens conventionally in the United States. None of that is necessary. These patients don't need trach tubes. I told you, some of our SMA type 1s are 24-hour vent dependent. They never went to the hospital. They never went into respiratory failure. Does anybody care? You ask your doctors that in England, if anybody cares, that the patients can get so weak they can't breathe and they don't even go into respiratory failure or need to get intubated. Ask them. Expert guidelines. Oh, in my next book, I use the so-called experts' words to basically condemn them, okay? Like they say, 3 extubation failures is indication for a trach tube. Yeah, 3 extubation failures to oxygen and low span BiPAP, of course. Plus, they don't use the cough assist correctly. I mean, then they say, well, patients who want trach tubes should have them. Who in their right minds would want a tracheostomy tube when you don't need it? They obviously, they don't need it, but they don't know they don't need it because the doctors don't know how to take care of them without it. It's absolutely incredible. I have more. Look, you want to read all these stupid quotes, get a copy of my next book, and after you read it, you send it back to me, full money back guarantee.
Is that the one
something else. Excuse me?
Is that the one I've got, your book?
No, that was the last book. The next, I'm going to finish the respiratory care book.
Respiratory one, yeah.
No, I haven't finished the respiratory care management yet. Oh, these are the websites, okay? Well, the only website that's really working now, I think, is breathenvs.com. Now, I have to tell you honestly, most of the stuff in the book I'm trying to finish is really on this website. So you really don't need the book to learn how to do things right. You don't. But my patients are going to want this book for many, many reasons, you know? And also, the 4th book I'm working on, I'm calling it The Gospel According to John. Now, I know it's a catchy title, but I have to tell you, the last book that was written, The Gospel According to John, historically, there was no John because it was written in 150 AD, and the name John was tacked onto it by Bishop Irenaeus of Lyon to give it some credibility because John was a common name, okay? Historically, that's how it got the name, the Gospel. Mine will be a real gospel because my name is really John, okay? Right. So mine will be the first that's not fraudulent because mine will be a gospel according to John. And the book is going to be about a lot of things. I can tell you that. And so I tell my patients, when I autograph it for you, it'll be like having an autograph of Moses, you know? Or maybe John the Baptist. But if I get that 4th book done, you can be sure that I will be assassinated, whether it be by Christians, Muslims, Jews, you know, Hindus, communists, people who believe in democracy. Everybody will want to kill me. And when the book is, then I'll be a martyr. The book will sell, and the signature will be worth a lot of money. What's that?
You'll be a dead rich man.
Oh, right. That's true. That's true. That's true. So anyway, that's the 4th book. But I'm after I finish this, I'm going to work on a book on respiratory care in the United States, which I plan on releasing for general information, because we spend a fortune and die 4 years younger as a result, and get tubes in our throats that are completely unnecessary. So that's going to be my next book, okay? But this book is really neuromuscular disease. Okay, so now I think we're open for questions. Oh, this was my last book in 2004. And now this book here is the skeletal muscle volume of my next book. But this is not cardiorespiratory. So I'm working on the cardiorespiratory stuff, which is the most interesting. Now, they're selling this book on Amazon for $34. But then I'm supposed to mail it to you. But the mailing to England is $27.
Yeah, as we found out.
It's ridiculous. So if you want, somebody should buy 100 copies and so, I don't know. Look, this book is of interest for the orthopedic stuff, the nutrition stuff, and, you know, equipment and stuff like that. but it's nothing compared to the respiratory care book, you know, the next book, because there's a lot of extremely important, people don't die because they get stiff knees. They die because their doctors don't know how to manage their respiratory care. That's why they die. And the next book is going to explain that, which is why my patients are going to want it, okay? So honestly, the next book will probably be about $50, but it's going to be enormous. I mean, it's really a lot of material. And, you know, that book is worth any price for. Oh, you have this. I sent it to you. Okay, Kelly, yeah. But, you know, it's very expensive, $27 to ship it. I know. I sell it for $20, which is like nothing. But in the United States, it only costs $5 to ship it.
Yeah.
But to England, it's $27, you know? So I say to people, if you really want this, wait until the next book is done and get both, because it's worth $100. I can tell you that. You will love that book. And it'll be less than $100, even with the shipping to England, I'm sure.
Yeah.
Okay, so that's a plug for my next book when I get it done. Full money back guarantee, I assure you, but I will sign it. And you know what I think about that. That
Yeah,
could
you
be
signed
valuable.
mine.
That could be valuable someday. Okay, so what questions do you guys have?
Okay, so you go on about how a child with or an adult with SMA should never be tracked. What
Right.
about when they've got a floppy airway or secretion management as well? A lot of children struggle with secretions to the point where they're having to be bagged 3 or 4 times a day. And the only option they feel is
No. They need to have the cough assist used on them 3 or 4 times a day, not be bagged. Okay, that's a very interesting point that you bring up, because I didn't mention this. For SMA type 1,
Yep.
The intubation rate, even for my patients, is 0.6 a year until the 3rd birthday. Then it's 0.3,
Yeah.
and after that, it's less than 1 every 10 years. So in other words, once my patients get to 5 years of age, they almost never get hospitalized again.
Yeah.
Why? Because they're able to cooperate fully with the cough assist, okay? Now, before that age, they do. The cough assist doesn't always work adequately, and the patients get pneumonia. Here? No, here. Yeah. So no, that's a very good point. So they may need to be intubated when the cough assist. Now, most of the time, the cough assist will avoid the intubation and the pneumonia. But like I said, once a year until the 3rd birthday, it doesn't surprise me that my patients do get intubated. The trick is, excuse me, yes, hello? Yeah, the trick is this. When the patient is intubated, the doctors need to use the cough assist through the tube correctly to get the saturation back to normal in room air to extubate them to non-invasive support.
But I think that's the trouble. I think a lot of them
Right.
extubate before they're even well enough to be extubated. They don't.
Right,
go-
that's right. They want to trach them.
Yeah.
So, but I tell my patients and their families, refuse it. They cannot trach your child if you don't consent it, and make them do what we do, or at least try it.
The Brompton don't push for tracks actually at all. They're actually quite against it. They want to manage everything.
Well,
by
because Michelle is there. Michelle Chaplin is there.
Yeah.
And Dr. Simmons, I know that.
yeah,
but-
and Professor Bush as well.
And who?
Professor Bush, Andrew Bush.
Oh, yes, he's wonderful. Yes.
I know Vinny's under him. He's amazing.
And who?
My son's under.
Oh, okay. Look, you know, I love Michelle. She's wonderful. And Dr. Bush, too, they're terrific. They are not on my website. And the reason I think they're not on the website is because if they go on my website, all the neurologists in England would hate them, because the neurologists have not done anything to stop their patients from going into a respiratory failure for the last 40 years. And they know that I know that, and they don't like it, because I've said that 40 years ago. So I really think that the reason that they're not on my website is because the neurologists would not like them in England, because they know that I've been very critical of the neurologists in England for the last 30 or 40 years.
Yeah.
Honestly, that's what I think. But you're right, they do a good job. But I'll tell you what the problem is, I think, that the patients who come to the Brompton, when they go back home, they get hospitalized in their local hospitals, and that's when the critical care doctors want to trach them, right?
Yeah, it depends on the relationship with your local hospital, to be honest.
Right. And I think that's what the problem is. And that's what the problem is a lot of places. So in the United States, if there are patients who contact me from every state in this country, and I tell them you refuse the trach, and the doctors say, 10 doctors say you've got to be trached or you're killing your child, blah, blah, blah. And they say, no, I'll never agree to the trach, call Dr. Bach, right? So they call me and I explain to them how to do it. Now, sometimes they try. Usually they don't even bother. They say, okay, we'll send the patient to you. And they get transferred here and we extubate them.
Yeah.
But the insurance has to pay for them to come here, because if they are convinced the patient will never agree. I have had people, babies, intubated for 6 months.
Yeah, I've known
waiting for their insurance company to pay, failing 5 or 6 extubation attempts in Puerto Rico, in North Carolina, in Texas. 4 to 6 months intubated, waiting to be transferred to me. And I've extubated them in 24 hours and sent them back home within 1 or 2 weeks. Okay, so this is the reality. These patients do not need to be trached. They can always be extubated without being trached.
But how do we change this? How do we change
in the United States, we do it by my patients refusing. Now, when they refuse, I get to be the one that ends up extubating them, because usually the local critical care doctors don't learn this. They, okay, it's easier, we'll send them to you. Because our therapists have never been in service in the cough assist. We don't want to have a family member using it on the patient in the hospital. You know, they have all these excuses for why they don't want to actually do what we do, you know, but they're excuses. This is not rocket science. If they reproduce what we wrote in those 2 articles on how we extubate unweanable people, they can also do it, but they don't want to take the time to learn it. They don't want to take the trouble. Plus they're a little bit afraid of extubating unweanable people because they've never done that before, you know? So I understand that, but every now and then there's a critical care doctor that does learn. Usually they're not in the United States, you know? So no, really, because if you look at the website, most of the centers are in South America and in Europe and in Japan. And the reason is because in South America, they don't have any money. So they actually try to keep people healthy. Nobody tries to keep a patient healthy in the United States. You cannot make a living on keeping anybody healthy in the United States, okay? That's just the way it is.
Yeah.
And if it's a rare disease and you've got to learn a new way to do things, there's no incentive for that because it's just not incentivized. I'll tell you how it works. American doctors are paid by something called RVUs, regular value units. Now, I get 1 RVU, less than an RVU, for spending an hour and a half teaching someone how to stay healthy. You get 11 3/4 RVUs for putting in a trach tube in 15 minutes. Why would anybody want to take the time to learn how to help anybody stay healthy when they can get 12 times more money and 4 times less time by sticking a tube through their necks?
What baffles me is how they sleep at night, though.
With a trach tube? Oh, you mean the doctors?
Yeah,
it's very simple. They're in denial. They convince themselves that patients are better off with trach tubes because they haven't read the 2 chapters in my next book about why people die with trach tubes. Because their patients don't die with trach tubes, because once they trach them, they go to they go out to the community. They go to a rehab center or a nursing unit, and they're the ones who take care of the trach tube after that. The nursing vent units or the home care, see? So it's not their problem that the patients die from the trach tubes, you see? So that's why they're not concerned. Oh, so now let me think, did I answer your question? Okay, so the answer is, even with ideal care, even in our hands, it's not unusual for the patient to be intubated almost once a year until the 3rd birthday.
Yeah.
But like I told you, Nikki there, who's 27 now, was literally intubated 10 times before the age of 4.5. But each time when they couldn't extubate him elsewhere, he got transferred to me.
Do you think that comes down to training, though, from the hospital towards the parents? You know, if you're trained by a good centre, like Vinny's been intubated 3 times.
What you really need is a critical care doctor who wants to do this. Now, Dr. Bush is a pulmonologist, but does he do critical care?
Yeah, he comes
Well,
around.
Well, then he's the one who needs to do this.
He's amazing, honestly. Like literally, Vinny's been intubated 3 times and he's 5 years old. He's been out of hospital now 2 years. The last time was RSV.
Okay, so why isn't he on our website? I mean, I'd be happy for Brompton to be there too, but Anita really didn't want it, you know, and I don't think she wanted to aggravate the
I'll speak
neurologist.
to them.
Excuse me?
I'll have a word with them because I think it's important, because if anything, I think that they follow your guidelines more than anywhere, to be honest.
No, I agree with you. In England, there's no question about it.
No.
And I know Dr. Bush too. I mean, I know he wants to do this and he's been doing it.
For years.
You see, if this were the United States, then the patients would say to their doctors in York or in Edinburgh, I am not going to agree to a trach tube. You transfer my patient to Dr. Bush. And they would have to do that, even if it took a few months.
No, they don't actually. If they feel that they can give adequate care to the patient, they do not have to transfer them by law.
But then they can trach them against your consent?
They can do whatever they feel. And if they...
Well, you have to sue them. No, you have to go to court. You got to go to court.
I know a few that have actually, but...
No, but they need my help. If they want to sue a doctor for putting in a trach tube, they have to have my material. So I can explain that they're absolutely wrong. Didn't need a trach tube, and I can show hundreds of patients like them. You understand what I'm saying?
Yeah, I mean, some centres in the UK are absolutely shocking, and still to this day, absolutely shocking.
That's depressing. I mean, if they can stick a trach tube in someone's throat without the consent of the family or the patient, that's terrible.
They involve social services. They can actually remove you as carer of the child. They can take away all
but wait a second. Let's say the mother and father get a lawyer, and they have a letter from me saying that it's the doctors who are making the mistake.
Go to the high courts.
Right. But that's what I'm saying has to be done.
I know several who have gone to the high courts, but there has been orders where I know one child, probably about 4 years ago, Vinny was actually very young, they couldn't extubate this child, but I don't even think they tried extubating to BiPAP. This was in Northampton.
Sure.
And they actually ordered the child to be removed from intubation and left to pass away.
And die.
Yep. And the child did die. But baby RM, the name, Romani was the name.
But wait a minute, didn't they say to the parents the child needs a trach tube?
No, nothing. They actually just removed their ventilation tubing and passed away.
And the parents went to the court saying, I don't want my child to die?
Yep. And the court ordered that there was nothing that could be done, that this child would have no quality of life.
Well, see, they need some. Nobody argues with me in court. Look, let me tell you something. You know what my credentials are like? I published on quality of life, on life satisfaction with SMA. I published on every aspect of SMA, you know. They really needed me to explain. And I'll tell you, the judges and the lay people, when I explain this stuff to them, they understand it a lot faster than the doctors.
Yeah.
Because the doctors have paradigm paralysis. They think in terms of quality of life, but it's not quality of life. It's life satisfaction. My 25-year-olds who can't move a muscle, they don't want to die. They're actually satisfied with their lives.
Yeah.
Now, the people who make surveys about quality of life are always people who don't have any disability, who decide somebody else has a disability to rationalize to themselves not to treat them.
Yeah.
You understand what I'm saying?
Yeah, I've always argued this with Vinny, because he's happy. He's happy.
That's why you need stuff that I write to present to the judges and the lay people in the courts.
It's changed worldwide. It's not just the UK, it's everywhere.
But it's changing now. No, this is changing, and I'll tell you why.
Because of treatment.
In the United States, the neurologists felt that the quality of life was bad. All the kids should die until nusinersen became available.
Exactly.
And as soon as nusinersen came available, now these neurologists who never wanted to keep these kids alive are doing it because they could get paid for administering the medication. And I swear to you that the thing has changed totally in the United States. Now all the neurologists are actually wanting to keep these kids alive, but they're still letting them get trached.
Yeah.
Because they don't know how to do it non-invasively, neither do the pulmonologists. But when they get intubated, if they don't agree to the trach, they get transferred to me. that's what happens here. So number one, you have to make the judge understand that it's a question of life satisfaction. And life satisfaction depends on whether you love somebody and they love you.
Yeah.
The people in the families who feel that they are loved and taken care of by people and who love them, they never want to die. You know, it's that's just the way it is. So, you know, people have to learn that. So that was an excellent question. And yes, people can need to be intubated until they're 3 or 4 years old. But when they get intubated, the doctors have to learn how to extubate them. And if Dr. Bush is doing that, he should be doing that for everybody in the country. You know, he really should. And I would love to have him on my website, so when people contact me from England, I can refer them to him.
Yeah.
Because they have to know that he will try to do it. They have to know that he will try to do it before they can demand to be transferred to him.
Yeah, well, that's what happened with Vinny, actually. This is exactly what happened with Vinny. He was transferred to the Brompton when they had him on Optiflow.
Well, no, there's something called NAVA, which helps a great deal in extubating SMA1 babies. But tell me, Dr. Bush works at the Brompton too?
Yeah, he is. Yeah, he's a main consultant. Well, Professor Bush is a main consultant.
For critical care?
No, but I think he oversees the critical care because whenever his patients are in,
Great.
he comes round and assists and
Oh,
tells.
wonderful. No, that's great.
He's
That's
amazing,
great.
honestly. He's amazing.
Well, send me his email and I'll contact him again.
Okay.
Even if Anita doesn't want to be on the website, maybe Bush would want to. I know
Yeah.
Michelle would like to. Michelle Chapman would like to, you know, because
Yeah.
she knows what we do.
Yeah, she's very good, Michelle. We've spoken to her a couple of times. All right, let's move to the next question. So, chest deformities. We're seeing quite a lot in the UK. Like the sternum sticking out quite a lot, and they're becoming quite disshaped. I mean, is there any way to correct that with ventilation? Is that to do with the pressures of the cough system?
I didn't quite get the question. Chest what?
Deformities. So we're seeing a lot where the sternum is really sticking out quite aggressively.
No, say it again. Chest?
Deformities.
Oh, the chest deformities are caused by not being put on, you know, again, if you have paradoxical breathing, you need to reverse that during sleep. None of my patients have pectus excavatum or funnel-shaped chests because they will put on non-invasive support settings.
You will normally find that the kids who are getting this are from a certain hospital where their standard SMA pressures are 10/4.
Which is useless, absolutely useless.
Yeah, I know.
Absolutely useless. Right, that's why. What's the next question?
Are there any documents that can support no oxygen use or Optiflow use in SMA?
Of course, I've written many papers on it, but look at my CV. Oh, I got one nice one for you. I have one on oxygen therapy, and that 320 patients got intubated because of the oxygen they were put on. That was a paper that I published only a couple of years ago.
Could you email that to me, please, so that I've got it?
Yeah, I can do that. Send me an email and I can send you that paper. But, you know, there are other papers too. A lot of what I've written does go into that, a lot. I'm not the only one.
No,
yeah, I
mean,
can send you that one.
I won't use oxygen.
See, but that one wasn't specifically about SMA though. I don't remember how many SMA babies were in that. But you have to really look at my CV or go on that website and take a look at what's on there. Because I normally put references for these statements, you know.
Yeah, I definitely need something because it's even still going on to this day in the UK that where they want to give them oxygen because of low saturation, but obviously BiPAP.
No, but obviously the oxygen is not the treatment. You got to treat what's causing the low saturation. It's either ventilation or mucus, obviously. I mean, see, that's what I'm talking about. If I explain that to someone who knows nothing about medicine, they understand that immediately. Why do these doctors not know that?
I don't know. It baffles me, to be honest, because it makes perfect sense in my head. You're just covering up the issue.
That's right. But it's worse because it's driving the carbon dioxide through the roof.
Yeah, well, it nearly killed Vinny. It literally
kills everybody. Kills all these patients. Let me tell you, if you or I walk into a vat of fermenting grapes where the CO2 is 200, you and I would stop breathing. It's true. They're driving the CO2 up over 100, even over 200. And then the patient stops breathing and they intubate him and they say, oh, now your kid needs a trach. Yeah, he needs a trach because you don't know what the hell you were doing. That's why he needs a trach. I'm telling you, honestly.
Okay, we've got another question. I am an adult in the UK who has never needed much respiratory care and have a team who are not used to treating SMA, and they are adamant that I need CPAP. Is there somewhere I can direct them to show them that CPAP is no good in SMA?
Well, again, you got to go through a lot of my articles, and it's good that they're asking these questions because I'm working on this update of my book now. So I'm going to go back and look at it and see what I wrote about that, because I understand that you have that problem. See, if they would send her to a polysomnogram and they would say, you have what obstructive and central apnea is, therefore you need CPAP. Now, they could put her on the CPAP and the apneas and obstruction would go away, but it doesn't correct the carbon dioxide, you see?
Yeah.
Now, if her vital capacity is essentially normal, then the CPAP is fine for her because you're really treating obstructive sleep apnea.
Yeah.
The problem is when they give you CPAP and your CO2 is elevated. Because if the CO2 is not normal during sleep and they give her CPAP during sleep, the CO2 will just get worse until she stops breathing. So, you know, it's a complicated question because I don't know what her vital capacity is.
Yeah.
I don't know what her carbon dioxide is either during the day or at night. If you have a normal vital capacity and you have symptoms of obstructive sleep apnea, you need CPAP. But I am not convinced. First of all, I don't know what type SMA she has. Type 3, type 4, I don't know.
Type 2.
If she has type 3, her vital capacity is probably not normal or even close to normal, which means she would get far more benefit by resting her muscles than by clearing away signs of obstructive apneas.
But what I don't understand is because obviously like BiPAP would support your inspiratory and your expiratory muscles, surely it would be used for SMA because it is a muscle weakness. It's not the fact that you can't oxygenate your body correctly.
No, BiPAP is cheaper than a ventilator, and she'll probably never need a ventilator. So, and she can probably take deep breaths, so she doesn't need the air stacking or volume ventilation. Therefore, to be practical about it, okay, use BiPAP. But the fact is that any span on BiPAP will rest her muscles a little bit. CPAP won't.
No,
CPAP could help by decreasing obstructive apneas. That's good. But it's not going to directly rest her muscles a little bit. Or see, what I'm saying is that it really depends on her, what her vital capacity is, what her CO2 is. So it's not a simple thing to answer. Is there any harm in her using CPAP? Probably not, because she's probably strong enough that her CO2 won't go up higher.
Yeah.
But I don't know that for sure because I'm not monitoring her sleep CO2.
Yeah.
And they probably don't understand to do that either.
I don't know. They seem to do regular sleep studies in the UK, actually, every 6 months. We're actually.
But do they monitor the carbon dioxide?
Yes.
Usually they don't.
Yeah, I do home ones with Vinny.
They do?
Yeah, yeah.
They do transcutaneous CO2 monitoring?
They do.
You're a lot better than the United States then.
Yeah, they don't do it in the
better.
United States, do they? Because actually it's not really commonly used. But yeah, I use a full
No, that's good. Because you see, then if the CPAP relieves the obstruction and the CO2 doesn't go up, why not use it? That's fine.
Yeah, because it's something I have to do 6 months at home with Vinny as well. Right, I've got another question. Should I use cough assist as physio every day, regardless of whether I'm sick?
Yes and no. If you can air stack with volume preset, you don't need the cough assist for lung volume recruitment. If you can't get deep breaths or deep volumes by air stacking, even if you use a lip seal, a nose piece to air stack deep volumes, if you get a deeper breath with the positive pressure of the cough assist, then you should use the cough assist, or you can use both.
Okay.
So in other words, if you're using the cough, there's 2 reasons for using the cough assist. One is for lung volume recruitment, which is passive lung volume recruitment. So if you can't air stack well, you can use the positive pressure at 60 or 70 centimeters of water to expand your lungs. You don't need the negative pressure for lung volume recruitment. If you can air stack, you don't need the cough assist for that. Just air stack and use the cough assist when you get sick.
Okay, so obviously the stronger types can air stack, and obviously your type 1s would need the cough assist.
Right. Oh, type 1s can never air stack.
Yeah.
So they do need the cough assist for the deep breaths. Yeah.
It what though, with type 1s, what I always notice is that a lot of parents say that they take these really quick, deep breaths and their belly flutters. Now, a lot say they use this as a communication aid, but actually I noticed Vinny doing this before he makes a vocalization. So is he effectively air stacking?
No. By definition, it's impossible to air stack.
Okay.
You have to hold the volume with your closed glottis. You have to get a second volume on top of that. So it's got to be greater than your vital capacity. The deepest breath an SMA1 can do, we measure that. It's called the cry vital capacity. When the cry vital capacity is 50 milliliters or more, I tell the mother that that child will wean after we extubate the child. The magic number is 50 milliliters. When it's less than that, the child cannot breathe on their own, okay?
Yeah.
Now, if the child can breathe 70 milliliters and he's intubated, we extubate and the child weans. The vital capacity goes up, maybe to 80, but the deepest breath that child can take is 80. You cannot air stack beyond 80 because that's the deepest breath you can take, okay? So, no, now, these children do learn how to grunt. What they do is they take the air, and what they're doing there is they're going, ugh. They're using the pressure to help them clear their secretions, the cough.
Yeah.
Even at less than 1 year of age, they do that.
Yeah.
They understand.
Yeah.
It's amazing. They understand better than the critical care doctors who don't know how to increase their pressure to help them cough. They understand that better.
Made me realize what Vinny's doing then when he makes that.
Right.
Right, next question. Every mask I have tried causes sores on my nose and nasal pillows leak into my eyes. What can I do to prevent this?
We have absolutely zero problems with masks because our home care company tries a number of them. Now, number one, nobody should ever use the same mask 24 hours a day.
Yep.
Number one, our patients use nasal prongs during the day, nasal mask at night, or nasal pillows during the day and something else at night, okay? We never have problems with skin because of that. So you really have to try a variety and do not use any mask more than 12 hours. Okay?
Go, Marnie. Right. I want to have no track on my medical notes as a wish in an emergency, but do not want the doctor to assume that this means a DNR, so do not resuscitate. How can I make sure of this?
Yeah, the DNRs usually say you don't want any invasive procedures.
Yeah.
If you don't agree to be intubated, you can die. If you need surgery or you get a pneumonia, you can die. So I tell my patients to cross off the trach, but leave the intubation. Yeah. But then they have to know how to extubate you if you get intubated. Believe me, my articles explain that, my books explain that, and the doctors just don't want to take the trouble to learn how to do it. I mean, that's really what it comes down to. Now, if Dr. Bush does know how to do it, then he should be getting these people in England. He really should.
I don't think it's that easy here, to be honest. There's so much red tape.
Well, that's why it's got to go to court. You have to have someone like me say, my patients are 28 years old. They haven't been able to breathe since they were 4 months of age, and they don't want to die. They are, with 1 to 10, if they're satisfied with their lives, it's 7. Okay? Quality of life is your concept of their lives, not their concept of their lives. You know, stuff like that.
Yeah, no, I agree.
You know, yeah.
So we got another question about a sleep study here. When my hospital do a sleep study, they send an O2 monitor. Is this enough, or should I push for a sleep study that obviously measures CO2? Sorry.
No, you need to measure the oxygen saturation and the CO2.
And the CO2, yeah, it's pointless.
Yeah, nobody needs a polysomnogram, really. You don't need a polysomnogram. Certainly nobody with SMA type 1 should ever get a polysomnogram. No. Because they all have paradoxical breathing and they need ventilation.
Yeah. Should we have a plan in place for emergency care for COVID-19?
Excellent question. All right. COVID-19 doesn't kill anybody. It's our reaction to it that kills us. That's dependent on several things. So, for example, in the United States, 86% of all deaths of COVID-19 are people with diabetes, which means that they're older, they're fatter, and they have high blood pressure, okay? With COVID-19, if you have diabetes, you tend to be older, fatter, and with high blood pressure. Now, you have fat cells. The fat cells secrete substances that increase inflammation. And why diabetics are more at risk, we don't really know, but there's no question about that. 86%. Also, 60% of people who die are males. And if you don't have diabetes, less than 1% of deaths are people under the age of 60. All right? So my patients are young. Some are females. They have ventilators. And they have no risk factors for dying from COVID-19. Now, if you're using BiPAP, the hospital won't let you use it because the viruses will spray out of the holes. My patients don't have holes in their nose pieces because we use active circuits. I use ventilators, not CPAP or BiPAP, okay?
Yeah.
So that's one of the benefits. They can be totally sealed up and they can't spray the virus, so they don't need to be intubated, okay? So if you use an active circuit with non-invasive ventilatory support the way we do it, that's a big plus because the patients would rarely need to be intubated. They're young, they may be female. And what was the other advantage? I forgot. There's 4. Okay, so why being young is helpful. The thought is that when you're young, you have a more brisk antibody response. And when you're older, you don't. And the T cells come down and blast the virus and blast us too. And the cytokine storm, we die from that. That's what the thinking is. So if you're under 60, you're doing well. Oh, if you don't have diabetes, that's the 4th thing. Okay? So if you're young, no diabetes, you have a ventilator, you know, and if you're a female, my patients, I have many patients that are Orthodox Jewish people in the Bronx, in Brooklyn, and they've got 15 kids. All of them get COVID-19, and the only people who become symptomatic are the grandparents who die.
Yeah.
That's what's happening. My patients don't even get symptomatic because they're young and they're guys.
Yeah,
So,
a lot of people have said that actually.
Yeah.
Okay, my specialist says I don't need a cough assist, but I can't cough well. Is there a study I can show them to demonstrate the need for one?
Well, of course, of course. I did studies where anybody with a cough flow under 300, and the next year, if they didn't have a cough assist, they would get pneumonia going to respiratory failure. And nobody with cough flows under 300, under 300 who got a cough assist got pneumonia. It's a control study, all right? Look. Yeah. Why are these guys so stupid? I mean, if you don't have a cough flow over 300 liters a minute, you have a risk of getting pneumonia because you're too weak to cough. You say to these doctors that if you get bronchitis and you don't cough, how long will it take you to die? Maybe 1 hour or 2 hours. You have to cough. Yeah. It's a vital bodily. Why don't they understand that? Now, what is an effective cough flow? Look it up. Life said it's 360, over 300 liters. There are many publications that say now that you need cough flows over 300 liters a minute, including my own publications. Okay? Now, the lower it is below 300, the greater your risk. It's as simple as that. You can get over a mild cold if your cough flows are over 200, but if they're under 150, you're not going to get over anything without getting pneumonia and respiratory failure. You know, look at my articles on this, on my CV, you know. Get my book when it comes out, or even this book will tell you that, because now that study that we did was 2011, so that was after this book was published, but I'm sure it's on the website.
Okay.
That was for Duchenne. What else have you got?
Hold on 2 seconds, I've just lost my place.
Kelly,
right.
Let me ask you a question.
Oh, go on then.
I have to video a lecture for Japan in the next week or 2 for at least an hour. Now, by any chance, do you have a video record of this?
Yes.
Well, if you can send me them. Excuse me?
It's all being recorded, so yes.
I guess you'll have it on a website, right?
Yeah, it will go on to the TreatSMA website, so I can send it to you if you want.
How can you send it to me? Can you send it to me like a Dropbox? How?
Oh, you'll have to ask Andy or Marnie because my technology skills are absolutely...
Yeah, me too, me too. Marnie, how can you send this to me? Like an hour lecture?
This recording will go onto our cloud. We can then download it and send it to you via WeTransfer. So you do it via email, it'll send you a link. You click the link and it will download onto your computer.
Oh, so I suppose I could do that to the Japanese. I could say, use this for the first hour. No. If you send me a link, they should be able to then show this in their webinar, right?
Yeah.
Well, I'm going to try that. Oh, that would be great because that would save me a fair amount of trouble, you know? Although this was, no, you know what the problem is? This was specifically about SMA though, you know? And they want a more general lecture. So I may have to do it again anyway, you know? Yeah, maybe.
We'll get it sent over to you and then
Yeah, but
you
send
can
me the
use
link anyway.
See what
Please.
Yeah.
Yeah, send me the link. See, I'm used to working with files, you know, like a MP4 file or something like that, you know?
No, I'm used to not working with anything at all.
You know, yeah, right.
So
All right.
the way we'll send it, when you download it, it will download as an MP4.
Oh, really?
So, yeah.
If I can
Yeah.
download it to MP4, that would be interesting because then I'd have it on a file and I would have some understanding of that. I
Yeah,
understand that a little bit better, you know?
Listen,
I'm still using DVDs. I'm using DVDs. Oh, let me show you. I got to show you my Apple phone. This is my Apple phone. All right? It's my Apple phone. Now I got to tell you something. When I go to a jazz club in New York with this phone and I pull this out, all the young ladies around say, "Woo, look what he has. He's got a flip phone and it's got an Apple on it, you know?"
Wasn't that from like 1999?
I have no idea because I never had a cell phone until about a year ago.
Oh my God.
I didn't want to have a cell phone and I regret it to this day that I have one now. But subsequently I've learned that the young ladies find this fascinating. You see? I mean, it's like, wow, it's really so, you know, it's better than having a poodle on the beach.
So it's actually your pickup line.
Yeah. Well, you know, it's too late for that for me, you know. But I get a lot of young people come here to learn, you know, respiratory care of these patients, and many of them are single. So like I'll go to a jazz club with them in New York and pull this out, and it helps them out a great deal.
I think me and Marnie need to come to New York. Right.
You know, I'm supposed to have a telemedicine visit at 4 o'clock, and I noticed that we are getting close.
Yeah.
Yeah.
It is 4 o'clock now. All right.
Right.
So
Hands up then.
look, if they have the questions they have, you can send me by email, and I will answer them.
Yeah, I know you will. You always respond.
Yeah, I'm pretty good with emails.
Yeah, you
I did that before I got this cell phone, you know. So I always told people to email me because I could email it much faster than, you know, talking to people on the phone.
Yeah, I'm like that actually.
Yeah. So this has been a pleasure. It's really great to see you guys. Send me the link and an MP4 file if you can.
Yeah, we'll do that.
You know, in Japan, they want an MP4 file. That's what they want. I should tell them this is like an emphasis on SMA, you know.
Literally, I have no idea what an MP4 file is, so I'm just going to leave it to you.
I don't really understand it either. Yeah. Okay, so I guess we'll break up.
Yeah, thank you. It's amazing. And our next
Anytime.
webinar is Friday with Dr. Giovanni Barnanello. Did I say that right, Marnie? Some crap. On metabolic nutritional management in SMA.
Kelly, next time you see Michelle, and
Yes.
definitely Dr. Bush, ask them to please come on our website.
I will do. I speak to Bush all the time because I'm annoying.
Okay, great. So we'll see you next time, okay? Maybe next year or whatever.
Thank you.
Thank you very much for tonight. Thank
Marnie,
you.
I don't know how to even get off of this. I have no idea. So stop
I'll
sharing.
end it. Don't worry, it's fine.
You do it.
Bye.
Bye.
Bye-bye.
Bye.